Good afternoon, everyone. My name is Len Statham. I am the Director of Employment and Economic Self-Sufficiency Initiatives here at NIAPRS. I want to welcome everyone who's here to join us for another great MRLC Medicaid Redesign Learning Collaborative webinar. As most of you know, who've been with us for a while, we've been bringing you some fantastic webinars on current topics that have really been useful to all of us, not just at NIAPRS, but across New York State. And today, much like in the past, we are going to bring you another great webinar. Healthy Agencies Create Healthy Communities, 5 Tools to Prepare. Unfortunately, we are having some technical difficulty related to the PowerPoint. And so we're actually going to continue to have the webinar and have a conversation with Dave Bucefaro from Foothold Technologies. But before we do that, I want to talk and let you know what the agenda is. Again, this is an introduction. My name is Len Statham. And for those of you that have been with us for a while, you know that Edie Swartz usually does this, who is our Director of Systems Transformation. And from now on, I will be joining you each and every month to bring you some more exciting webinars. But first, as always, I want to introduce you to our fearless leader, Harvey Rosenthal, who will give you an update of all the things that are going on in New York State. Harvey?
All the things that are going on? That's going to take a long time.
Everything.
So, okay, all right. Listen, good afternoon, and I apologize on behalf of NIAPRS that we're having this problem. So I don't know if your screen is like mine, but you're only seeing the one slide. But the good news is it has my email address, and if you have any questions, you can certainly email me. If you are new to NIAPRS, you'll know that NIAPRS has been around for 31 years, and probably for the last 25 has morphed into a peer-led statewide coalition of people who use and or provide community mental health recovery services. That's peers and providers or peer providers, who are all joined together to improve services, social conditions, and policies for people with psychiatric disabilities by promoting their recovery, rehabilitation rights, and community integration. We do it through advocacy, lots of state and national advocacy. We do a lot of training in TA, Edie, Len, and a bunch of others in that division. We have a peer division where we've created the Peer Bridger program and other models within managed care and similar models. Len is our economic and employment expert, and he certainly does a lot of work there and is available. And where cultural competence is a big feature, a big value for us at NIAPRS. If you could see the slide, you would see really a standard slide that really I've been using for years that the health department gave out. So what you know now is that we've carved in the behavioral health benefit for people with the most serious mental health needs and addiction related needs, and that money has been packaged and given to health plans that have agreed to take on this new product called the Health and Recovery Plan. And you know that they're getting about $2,500 a month, which is more than they got before, to serve our folks, and that's across behavioral and physical health. And that a lot of the way the design works is that people are enrolled in the HARP, and their services are they're engaged into a health home where their plans are developed, assessments are done, and plans are developed, and referrals are made to a network, including now home and community-based services, which for the most part are services that have been historically offered in little grants in state and local aid, employment, education, peer support, family support, crisis services, and what have you. Self-directed care, which is coming next year in a pilot format, and eventually will be part of this benefit. In terms of where we are, and I think it's commonly known that this approach has not worked as well and as quickly as everybody wants it to. The HARP enrollment, which was originally forecast at about 140,000 statewide, we have about 80 as of November 3rd, 44,000 of which are in New York City and about 35,000 upstate. So there's certainly a lot more enrolling to do in terms of the HARP. I was at a meeting where they explained that 1/3 of the people that have yet to enroll, 1/3 are not eligible because they went through the exchange and they're not able to come over. 1/3 are people where there's bad addresses, and interestingly, 1/3 are people in the mainstream plan, which is also carved in, but only has the traditional OMH services and not the HCBS. And so there are folks that are not coming over to the HARP, but staying in the mainstream plan with the added benefits. You know, too, that the HARP, the health homes have not been particularly successful, very candidly, in engaging enough folks of that group and doing the whole process of engaging, enrolling, sitting through a number of assessments, developing a plan of care, and then referring people to providers, most notably the health, home, and community-based service providers. I think I was told there's about 1,500 assessments that have been done, only 140 plans of care. So we have this is a huge issue that advocates and certainly state government who owns that is really trying to fix. There are a number of reasons that people would speculate. The process is rather complex. The assessments are complex. The workforce, we believe, and we do some of the training, really, you know, we can't do enough sort of training in general, but certainly with the group here, some folks, you know, have some expertise and some experience, some don't. Supervision, the caseloads are high in some cases. We not necessarily are using peers enough. So there's a number of workforce issues. There's the complexity, and there's the reimbursement and the incentives. Really, they're not really, in my judgment, they were high enough to get this done. So these have to be fixed, and I know the health department in particular is very focused on it, but we have a ways to go. There has been an indicator that the health home needs more juice, more smaller sort of client to staff sort of ratios, and more training. And specialized sort of programming, because they've done Health Home Plus for state hospital residents, adult home residents. There are pilots for people that are justice involved, and there are people with outpatient commitment orders. So there's already 4 specialized health homes that sort of indicate that more is needed here. In terms of DSRIP, and this is where I wish I had the slides, but you know that the DSRIP in New York is the Delivery System Reform Incentive Payment Program, and you'll know that this affects the broader Medicaid program, 6 million people, and that DSRIP is the federal government's giving New York $8 billion over 5 years to form these regional networks to improve care, particularly for costly conditions, folks with costly conditions, by creating brand new networks, you know, that bring all kinds of groups together, mental health, you name it, social services, and that they're really intended to do improve care for diabetes, hypertension, asthma, depression, mental health conditions, COPD, AIDS, HIV. You know, if you were reading the e-news this week, and if you see that's my email address there, please email me. The e-news comes out every day. And what I ran on yesterday was the announcement by the assessor of DSRIP that said, not surprisingly, everybody knows this, that the PPSs have a lot of money to buy services from partners in the community, but they have not sufficiently engaged them, even though they've gotten 70% of their money, which is tens of millions of dollars. And that the funds, you know, the contracts have not been made, the partnerships have not been developed, and the state is clearly, the assessor is saying this needs to change, and they say specifically as soon as possible. So this is high on the plate, and it confirms what advocates have been saying. NIAP is doing a lot of advocacy here. I'm engaged in a number of the groups, but certainly consumer education really is important. Just had actually a meeting a short time ago with a health department official on this topic of consumers need to be educated, engaged, and activated in this. There's a critical role here for the recovery sector, as we mentioned earlier, but that's not really happening at this time in the way that it should. There'll be pressure from the state. I would predict there'll be a run on contracts under this kind of pressure, which would be good. But that means behavioral health providers need to really be sort of ready to play at this level, be in networks, have the kind of platforms and infrastructure that David's going to be talking about, and really be able to formulate value-based propositions really the kinds of services that really are needed and that PPSs would understand and want to buy. So NIABRA is very involved in that. I've been working a lot with KPMG and the health department and on this, trying to create like a nexus around value-based proposition for behavioral health providers. I'll have to explain that another time. So now value-based payment, you'll know that after DSRIP is over, and even along the way to DSRIP being over, the goal of DSRIP is, and value-based payment of DSRIP is to improve these new networks that save money and improve sort of collaborations. But then we move to a value-based payment system where all payments are really tied more to outcomes than they are to fee-for-service. And provider networks are really now taking the risk, at least the bigger ones. So that means that providers, sort of networks in value-based payment can make more money if they make savings. And so that becomes a gain-sharing environment. There's a lot of work. I won't be able to explain this today, and we could maybe do a separate webinar about it. But this issue of gain sharing by providers could go either way. Providers could start withholding service because they make sort of profit on that. As an advocate, I have to watch out for that. There's something called attribution, which is basically that people in value-based payment, there'll be a central locus. They'll be attributed to a practitioner. It's been decided by the state that that's going to be the primary care doctor. Although I believe they've agreed, I've been advocating a lot for this, and I think others have too, that a behavioral health provider could be this attributed party. To be attributed party means you're sort of seen by that new Medicaid transformed system as the go-to person for that person's care, and frankly also in the lead to make some of the money if there's gain sharing. I've worked really hard on consumer education, ombuds, incentives, privacy protections. That's my real focus. There is a suggestion that people who are in Medicaid, as we move to value-based payment, would no longer have to sign essentially consent forms, but that would be included as part of the enrollment. And maybe people would be educated about this and be able to opt out, but it certainly is a significant move where your information would be shared, could be shared if this goes through, and you wouldn't have to agree to it, but you could agree for it not to happen, assuming you know about it, and that was the purpose of my meeting about education. More to be said about that. That's by no means happening, but it's on the bubble there. Recovery outcome measures, we were in a meeting yesterday about that. So we're really focused on that. The social determinants of health is really important too, and I guess I'll get to that some other time, and I'll end by saying that if you get the e-news, you'll see yesterday that the health department has advertised a town hall on December 16th here in Rensselaer, across the river from Albany, where Jason Helgerson and all comers can meet and get an update on value-based payment, and particularly around how the field can be educated around value-based payment. So I'm going to stop now and give it back to Len. I hope this was helpful. And again, we can do a separate webinar on this. I'd be happy to do that. Thank you.
Thank you so much, Harvey. Before I introduce our featured speaker today, I do want to have you pay attention to the right-hand side of your screen. You will have the opportunity to answer questions, or to ask questions rather. And so you can type questions during Dave's presentation, and we will be asking those questions on your behalf. David Bucciafaro came to Foothold Technology after more than 25 years at the New York State Office of Mental Health. And most recently, he served as the director of the Rehabilitation Services Unit. And he really does bring a visionary yet practical approach to program development, budgeting, performance management, and compliance. And during that time, he worked with both private and public stakeholders to effect significant changes to the systems of care. His accomplishments include the creation of the first fully medicated funded program in the nation. That's the nation, dedicated to the delivery of psych rehab services, and that was our IPRT model. And the creation of the innovative person-centered recovery-focused benefits packages known as PROS, which is our personalized recovery-oriented services. In his current role with Foothold, David shares his experience and technical expertise in developing compliance and program standards with providers and local governments across the country. David, we are so delighted to have you with us today. Take it from here. David?
Hi, everyone. Len, can you hear me?
Yes, I can.
Okay, great. Hi, everybody. Thanks for joining. I know you can't see the slide, so I'll try to explain these as best we can, but I do know that they're going to be available to everyone. So both the presentation and the slides you'll be able to access at a later time, if I'm not mistaken, right, Len?
Right.
Okay. So I encourage you to ask questions. I do not mind folks jumping right in whenever they want to ask something. It's fine with me. I'm going to try to convey to you my experiences around this concept of you can't really have a healthy community unless you have healthy agencies, and to pass along with you some ideas around different ways in which you can prepare your agency to be a healthy agency. Harvey, as always, shared with us insights that very few others can actually give, and give them in a way in which only he seems to be able to do. And as I listened, I was thinking to myself, oh my God, we've got all these changes coming now and all these things happening now. And I think it's sort of critical and important for us as we move forward to realize that things are not going to stay stable. They're not going to remain the way they were. We're going to have to get used to doing some things differently. We're going to have to get used to adjusting the way we do our work. And so I want to give you some tools that I have found over the years, both at my time with OMH and actually more recently in my travels across the country, that really enable you to hopefully be ready and move forward. So when I talk about a healthy community, I'm really talking about 4 different areas. I'm talking about having healthy participants, probably the first and foremost and most important goal that we all have. I'm talking about having healthy agencies, you the providers being healthy in a sense of both your approach to the way you deliver services, but also financially and also from a growth perspective. You want to make sure you have healthy staff. Staff are so critical to the health of the individuals that we're serving, and we want to make sure that we're giving them the tools they need and giving them the ability to be creative in what they do and move forward with their role as helping individuals. And the last is, by doing this, I really believe strongly that we're going to be able to build healthier communities. We're going to be able to live in areas where we really do have a concept of an integration of healthcare and physical healthcare and socioeconomic conditions, and things really will start to improve from that perspective. So why do we have all this fuss going on right now? I mean, basically, you've probably heard this in different ways multiple times, right? Behavioral health individuals have higher than average rates of emergency department use visits, right? We have higher hospitalizations. We see higher recidivism rates. And in recognition of that, there's now a belief, and luckily for us, a belief that behavioral health is a core part of the population health in a community. And the strategies that Harvey talked about and others talk about, and I'm sure Jason will talk about when you have the opportunity to talk with him, is this concept of the integration of behavioral health into the general healthcare field, and what strategies are being taken to help with that, such as DSRIP and others. It all stems from basically the Affordable Care Act, and even before then, the efforts to try to improve care in this country. You know, there's a number of targets that we've had, right? Let's improve the health of the whole population. Let's look at lower per capita costs. Let's look at improving the experiences that people have with participating in systems. To do so, let's start to look at reformed payment structures. Let's look at reformed healthcare delivery systems. And let's use a strategy that's somewhat different than what people used before, which is let's share in the savings that result from these improved cares across the system. And by doing so, let's try to provide better services to individuals that are participating in the programs that you folks do.
David, I'm just going to interrupt Harvey here. I'm told you might be able to, you have control and you might be able to move the slides. Is that possible?
Okay, I'll try.
No?
I'm clicking on them, Harv. Let me.
Nothing's going on? Okay.
Nothing's
Go
going on.
Go ahead. We'll continue to try to figure it out here. This is what we believe, but okay, go ahead. Sorry.
Yeah, sorry. So what are some of the primary characteristics of these entities that are starting to emerge? These affordable, I'm sorry, these care organizations, the managed care organizations that we're dealing with, the performance-based contracts that we're going to be looking at.
Excuse me, Dave?
Yeah?
You have control of the mouse now.
I have control.
Yes.
Ah, it's working.
Terrific. Okay, thank you.
Thank you. Ah, so we're looking at, let me catch up to where we were. Good. So as I was mentioning, we're talking about having processes that can measure and report performance outcomes, and we're looking at affiliations with hospitals and healthcare systems in which we have a really major impact into that system, in which we can help the population health of a community. So where do we fit in? There's really a clear confirmed link, right, between people's physical health and their mental health. That we know. We realize that that part of what we do is critical to the physical health of people. We know that people are diagnosed in any given year. We also know that people with serious mental illness have comorbid medical conditions. We understand that the volume and acuity of behavioral health individuals in primary care offices need timely access to care, and they often did not get that care. And we know that this managed model, Harvey's talked a little bit about this, and he's talked a lot about this in the past. This managed model of putting behavioral health as having a component within this healthcare system provides an ideal model in which individual costs and care can be managed, and still giving individuals the ability and hopefully the proper services that they need to move forward with their recovery. So what do you face today as a provider? All of these things and probably 5 times more, right? You have all of these things happening to you. You have instability, you have new populations, you have the Olmstead Act, you have all of those things that are happening. And what does it mean to you? Why do they matter to you? Well, many of them result in diminishing resources. You may feel like there's more money being put into things, and it may appear like there's more money being put into things, and there are very frequently. There's more money in housing, there's more money into certain kinds of care models, but remember that they come with it requirements that are not free. And so even though you're getting additional money, and you do have diminishing resources in which you need to manage with. We need to begin to really take hold of this integration of care. It means sharing of information. It means using information from other resources in the care that we provide. We always have ever-changing regulations. I know I was a culprit of this for many, many years at OMH, where regs changed all the time. What does come with a lot of these changes are going to be increased oversight activities. They may not be more frequently, but they're going to be different, and they're going to be intensive in different ways. Harvey touched a little bit upon this, but we are shifting from this concept of volume to value. And everywhere you see, there is a shift taking place from this concept of base payments to providers to those of a value-based payment. People need new work skills. Definitely makes us operate differently. I'll talk more about that shortly. And our good friend Richard Jaros, Dick always talks about we're moving from a budget to a business model, and we have to be prepared for that. And the only way you can be prepared for that is to have the information at your fingertips you need to be successful in the next bullet, which is around performance-based contracting. So how can you do this as an agency? There's really one major way. You need data. You need information, and you need the knowledge that it's going to bring you. But just having data isn't going to be the answer, right? You need to know the information you need. You need to understand how you get that information, how you take that information out. You need to do 2 things around culture. You need to establish a culture in which information and data is part of the critical thinking process that individuals go through. But in addition to that, you need to be able to retain your culture and who you are and what you do in light of all these changes. You can't be stagnant anymore. You have to constantly evolve. We, for many years, were able to stay very stagnant in who we were. If we were a shelter workshop, for example, we were good at it. We could stay that way. If we were an ACE program, we could be that and we could stay that way. If we were an IPRT, we had a niche and we could do that. The world doesn't operate that way. You need to use data to survive right now. You can't live the way you're moving, the way you have done in the past, without having data to grow and move forward with. So I'm going to offer you up 5, it's actually 6 to be honest with you, different tools that I think you can use to really help you with this concept of using data. And what does it mean and how do I actually use it? Now we're going to only at this point obviously get into a conversation that's at a higher level, but you know, those of you know me, I'm more than willing to chat with you about any of these and help you implement some of these strategies into your organization. These are really the 5 areas. There's 6 when you really break out collaboration and interoperability. But one of them has to do with accountability and meeting your obligations. The next is going to be to talk about a strategy of informed decision making in your organization. The next one is really going to be, what are the mechanisms or tools that I can use to really create a dynamic management system? Things change constantly. Those of you who follow health homes or are part of health homes, for example, know how things change. Those of you that were part of the PROS implementation know how things can change from meeting to meeting. The next thing is around collaboration and how we are not really standalone agencies at this point of time anymore. We're collaborators with other people. We have to collaborate to survive. Along with that is this concept of interoperability, and I'll talk more about this, but this is really the heart at this point of the way healthcare is going. And it's really the forefront of where quality care is moving forward to. And lastly, if you're a business, you have to market yourself. And we want to market ourselves without losing our culture, but where we're successful in marketing. So I'm going to talk about some strategies with each of these. Again, I invite you and hope you'll ask questions along the way. And from that, we can try to dive deeper into these. So I'm going to start with your obligations and accountability. One of the most important things that managed care organizations, and I can tell you from my experience with governments, is they look for agencies that have a high level of accountability. They want to make sure that they're working with agencies that can meet their obligations, both their external and their internal obligations. And so for you as an organization, you need to know who you have an obligation to. You need to understand who you're accountable to. And because we have to operate in a more effective and efficient manner than we've ever done before, we don't have the opportunity to really just capture everything, and that way we'll be covering our obligations. We can't do that anymore. We really need to know, well, if I'm not accountable for that or obligated to do that, that can take a back seat. I need to really identify what I'm obligated to and who I'm obligated for, and meet those needs. And so here's just a few examples, and I'm going to give you a way that you can hopefully take from this and do this exercise yourself. But when I worked with, these examples are actually from an agency I worked with in Atlanta a number of years ago that was really struggling with incorporating a housing program for recently released individuals from prison. So these were individuals who were identified as having a behavioral health issue. They were released from prison. They had met their obligation to the community and had served their time, and now they were coming out, and they really weren't ready for a halfway house, but they were ready to be in the community, and so they created a housing program, and they really struggled with how can they incorporate this into their organization. And one of the things we really figured out was that they were really scattered all over the place, the organization, and they really weren't able to adapt to this new kind of program. And so what we did was this exercise where we said, you know what, let's really focus on what it is you're really obligated to meet. What are the needs you have to meet, and who do you have to meet them for? So we identified government, we identified funders, we identified accreditation bodies, and a number of other external obligations they had. Internally, obviously, the single most important obligation are to the individuals that we're there to serve. It's to your board of directors, and it's to the staff who work in your organization. So what we did was we basically set up a set of questions. Who are we accountable to? What are we accountable for to each of those? Who's responsible? What are the metrics we're going to use to measure? And what's the frequency? And what we came up with is basically a spreadsheet that looks like this. What we did was literally, this is an agency of about 75 to 100 staff. So I was able to work with a couple of people there and actually do this with everybody over about a 3-day period. Some people have taken this and sort of done it from a staff grouping perspective. But what we did was we identified every person in the organization and identified what their title was so that we could group and lump together certain titles. We looked at who that person felt they were obligated for, and then who this organizational team we put together felt that they were obligated to. We identified how would they measure those obligations. So what would you use to be able to show your accountability to the individuals who you serve? Outcomes. They looked at outcomes and they looked at safety. Employment and hospitalization were two that they looked at. Level 1 and 2 incidents, which are the higher level of incidents, and other levels of incidents. And then they said, how often do I need to look at that data to know that I'm meeting the standards of what I've set forward in this organization? And so for the employment, they look quarterly. For hospitalizations, the executive director had a dashboard that said this is how many people were reported into the hospital last night or yesterday. They did a very similar thing for incidents. And we did this for every single staff person. Now, obviously, it may appear like this is harder than it really is. This is really not that hard. In one of your staff meetings, you give out a little chart like this, you ask everybody to fill it out, and you gather this information all up, and what you're going to find is what we found. And I've found this in almost every organization I've worked with and done this to. There is overlapping accountability, there is lapse in accountability, and there are individuals who believe that they're accountable for things that they really aren't accountable for. And a lot of their time is going into trying to meet those obligations as opposed to trying to improve what they're already doing. And so this is really the first area that I think before you can even move forward with a lot of these other things I'm going to talk about, you need to make sure your organization is organized in a manner in which your accountability is being met. The next one is informed decision making, and this is an interesting area that over the years I've sort of grown into, so to speak. I had always thought like it's really only the directors or the decision makers meaning the supervisors or the bosses, to look at information and look at data and really start to make a decision based on that. But it really isn't that way. It's everyone's job. It's the administrator's job, it's the supervisor's job, it's the clinician's job, it's the people doing oversight, it's the support staff's job. Everyone should be making their decisions based upon the data that they have available to them, both internal and external. There's a strategy, there's a concept in data-based management that talks about data being these pieces of information that don't tell you a lot, right? Red is a piece of data. Car is a data element. Drive is a data element. David is a data element. But when you start to merge those data elements together, you start to get information, right? David drives a red car. That's information. Now that doesn't mean a whole lot to you and doesn't really matter unless you piece other pieces of information with that. Like, I drive a red car and I deliver pizza on the side. And so now you know that if you see David in a red car, he might be delivering pizza. Now that's sort of a far out idea, but the concept is you're going to take information and you're going to put it into use as knowledge, right? So let's play this out in one of your programs. So let's say that you're getting good outcomes in one of your employment sections, right? But in the other one, you're not really getting good outcomes. Now, what you're going to want to do is to take information that can feed you knowledge around those two circumstances. Maybe it's different staff. Maybe it's a different curriculum. Maybe there's different individuals involved in it. Maybe it's in a different location. But you're going to take all that information and you're going to use it to make some decisions. It might mean that you move somebody from that program into a different program because they're not getting the outcomes that you're looking for. And maybe you're going to take the person who's really doing well in delivering outcomes and you're going to have them write a curriculum for you. You're going to use the data that you have available, turn that into information and use it. And I used to always wonder why this agency did real well and that agency struggled. And what I really started to learn was it was those agencies, it wasn't luck. It was those agencies that really used a knowledge-based approach to their decision making. And they fed it in with their gut feelings, but they used it at all levels of their organization. Clinicians who weren't achieving the kinds of results they wanted from the groups they were running would look at that information and they would modify what they're doing. Support staff would look at information like it's taking us X number of hours to accomplish this task, like to pick up individuals or drop them off. Maybe we should be looking at the way we're doing that. Maybe there's a better approach to that. And so everybody looks at the data from the administrators to the support staff, and they really are able to make a difference. Now, the biggest key to having an informed decision-making agency is really to make sure people have accessibility to the data they need. We've already identified earlier, when we talked about accountability, many of the pieces of data that people would need, right? But you have to make sure they have access to the data. You got to make sure that they're regularly using your system to pull that data out. Not all the information you need is going to be coming from your electronic health record or your files or what you have on hand. Some of this is going to come from external resources, and you got to make sure that people have access to those external resources. Excuse me. You have to make sure that the system you're working with can allow you to get the kinds of reports out of the system you need. At the recovery conference a couple of weeks ago, I was asked to identify some of the key areas when people are looking for either software or things that they could be trying to improve on. And one of the most important pieces is whatever you're going to do around data, make sure that the reporting structure you have is easily usable for the people who need to use it. So you can create ad hoc reports very easily at any moment you need them. You can store canned reports. You can download data into analytic kinds of programs that can really work with this data different than would be a traditional electronic record could do, or you could traditionally do with your paper record. You have to always look at your data If you have bad data, it's a lot worse than you think because you're going to be making decisions based on that bad data. And so make sure that the information you have is accurate. This requires training and retraining your staff. Don't skimp in this area. If you're offered training from your vendor or if you're offered training from the state, take it and use it. So this is a little tool for you. I'm not going to go through this in a lot of detail, but this is a guide for you to take. Make sure that you follow this when you're looking at accessibility of information. You want to make sure that people can sign in individually. You want to make sure that they can work through that it flows with their work, that they don't have to do too much to get to where they need to. We just talked about the data. I want to make sure that when you look at things, that's what you're doing. The next thing is around being dynamic. I can't believe how frequently I'm on all the health home calls, and I've been on mostly all the Medicaid reform calls that the public has been invited to. And Harvey could probably tell you even more and more stories about this. But things change constantly. Every meeting, something has changed. It may feel little, but it probably isn't little to your workflow. You have to have an internal process that's interactive, that takes the data and feeds it back into your organization. To do that, you need to be informed. You need to really participate in as many informational sessions you're able to. You need to have data at your fingertips, which we just talked about, from within your organization that allows you to make decisions that you need to make. You got to be flexible. You can't be locked into an approach and not be able to adapt readily. The only way you're going to survive in this new world order that we live in is to be able to adapt quickly to the changes that are coming down to us. And there's a strategy behind this. It really does have to do with you being prepared as an organization to make these decisions. For you to have the data, for you to be able to link that information so that you can use it to build your knowledge, and then to really use that knowledge to make your decisions. All of you have this thing called organizational memory. It's the accumulation of information, knowledge that you've had over your organization's existence. Use it. Keep it at your fingertips at all times. Don't be bound by the past, but also don't forget who you are and how you got there, because it's going to help you to move forward. The next area I wanted to just touch upon is this idea of collaboration and interoperability. We aren't alone anymore, right? We work with other providers. We have to work with other people. There's health home providers. There's managed care organizations. You may be a part of an individual's whole overall care plan. For you to be providing quality information, you've got to collaborate with those other entities. One of the ways in which that takes place is this concept of interoperability. This idea of being able to exchange information with other healthcare providers is really what's going to drive the next 20 years of healthcare. People are going to be making decisions based upon overall pictures of an individual's care and not only what they do in their little world. I participated, our company participated for the last few years in a national presentation at the HIMSS. HIMSS is this health information management system. It's one of the largest groups in the country, or in the world actually, that deals with health information. And we were part of this interoperability panel. And one of our role was obviously behavioral health data. And so we were the EHR that this pretend company had. And we went through this exercise where one person with the same health needs came through the system on one side with an interoperable approach, and on the other side where people depended upon working within their own environment without having information. That person on the left that went to this organization where every single staff person that dealt with this individual had access to the information they needed to have access to, not things that the individual didn't want them to participate in, but things they needed to have at their fingertips, the outcomes were so significantly improved that it just exemplified the importance of this concept of interoperability. You may have heard of health information exchanges, the RIOs, the Shiny. You may know that you have to give data to the health home. All of that is these interoperable concepts. We in this state have not done a really good job yet with it. We are struggling as a state to really be at the forefront of interoperability. We're trying, but it really does require some very finite and tough decisions to say that everybody is going to be able to download information in this exact manner, or download information to an entity. We're getting there. It's going to be more and more critical. What you're going to see probably in the next 5 years is more dependency and or more requirements from the federal government that information be electronic and not paper shared. And so this is going to just be a growing area that you're going to have to be able to adapt to. The last area I wanted to talk about was really around marketing yourself. Harvey talked a little bit about this earlier, and how our providers and how you folks are becoming HCBS providers and marketing yourselves as being able to provide these services. And so you have to be able to show what value you have as a funder. You've got to show what value you have as a partner. If you're going to be in a PPO, or if you're in a district type project, you're a partner. You have to have value for them to be able to want to use you. You're going to have to become more effective and more efficient. Efficiency and effectiveness will be drilled over and over and over as we move more and more into a managed environment. And you have to be good at person-to-person outreach. I would say that one of the areas that we've really struggled with in the health home world has been this ability to do a person-to-person outreach and to really be able to reach people at the point they're at and be able to market yourself or market the value of a managed environment of care. And when you go to a managed care company, for example, and you get that opportunity to sit down with them, and everybody gives niceties and they say, so what do? You aren't going to want to say, we're so-and-so, we're the premier provider or the only provider, or we're the top provider in this county providing these services. We've been in business for 40 years. The whole community recognizes us. That's not where we want to be. Where we really want to be is you being able to take information and show them all of those things are true. That's what they're going to want to be able to see. So how do you leverage data? The kinds of data you're going to need are going to be outcome-based information. You're going to have value-based information. I'm not going to talk a lot about this other than to say I do a whole webinar on this. You need to be able to figure out how much it costs you to achieve particular outcomes so that you can value your services for their worth. And you could sell them, as you should be able to the organizations who are going to want those services for the individuals, that the covered lives that they have. You need to build your staff expertise. You need to learn how to use your board to influence more the positive changes that your organization goes through. And as I just mentioned, you need to use data to tell stories. It's really critical. You know, I worked with an agencies who used to go into these board meetings and tell, you know, all these anecdotal things, and then they started to use data. And all of a sudden, this one board member spoke up and said, you know, I have access to this particular company. I bet you if I brought this data to them, they would love to see that your folks have a retention within employment of X number of years, because they have such turnover. It was you know, mind-boggling. And so just by being able to present data to your board, they built a whole new influence that their board was able to have for them. Now, I do want to leave you with this thought. When you do begin to manage with data, there's a number of principles that you really should continue to follow. Build a culture of accountability. It's everyone's responsibility. Don't lose your person-centered philosophy. It's clinically the right thing to do. It's ethically the right thing to do. If you can, learn to establish a concurrent approach when you're dealing with information, like an information, like a health record. Don't be going off on your own and entering data if you don't have to. Do it when the person's with you. Let them be a part of it. First of all, it's the right thing to do. And second of all, you get paid for it. If you're working with an individual, working around their goals and accessing their information and reporting and recording what you've done with that person is all part of a service. Don't lose your culture. You are who you are. Make sure you retain that. Make sure your consumer portal reflects your values and who you're about. Always look to enhance your organization with information. Don't necessarily jump on everything that's new if the information tells you that's not an area that works for you. If you do have an electronic record, you're probably in a little bit better shape around regulatory requirements. Because, you know, I know for us, I review every piece of what we do to make sure that it's within the regulations that we have, that the states that we work in have set. And so you got to make sure that you're first and foremost meeting those regulations, or you're not going to be there. Next, it's really reviewing your capacity constantly against an idea that you have. I worked with an agency in California, and they were an agency that dealt with foster children. And they looked in the community and they realized that, you know, people that aged out of foster care really oftentimes did not have places to go. And so they created an after foster care program. And they built these residences that were almost like, for the lack of a better term, these halfway houses or these transition centers for people. And they found a niche within the community of growth that was based on what they did really well, and they were able to sell themselves because they had the information to show how good they did in the area which they were working on. And it's really, you know, somewhat important. The last one here that's not listed and that I talk to people about is, it's very good and it's very important for you to retain your culture. And I believe strongly, and everybody that knows me will tell you that I've dedicated as many years as I've been in this industry to hopefully push forward the recovery movement and the rehabilitation program movement. But you have to do so with the idea that if you have no means, if you have no way of staying in business, you can't do any of those things. So make sure that when you look at your organization, that you look at the fact that if I'm going to do that, I've got to make sure I can afford to do it. I can afford to do those things that need to be done. I'm going to leave my information there. I ask if you have any questions. I'm more than happy to answer them. As I mentioned before, if you're real shy, I will be more than happy to talk to you outside of this call. I will tell you the best way to get a hold of me is email, because I'm very rarely in any one location with my telephone. So, Len?
Folks, you do have an opportunity to ask questions by going to the right-hand side of your screen, and there's a little category there, questions, and you can write your questions out, and I will be happy to answer them or ask them to David directly. But Dave, I actually have a question here, and that is, how do you handle people who might be adverse to change, in particular to electronic information?
Very good. I will tell you that my thought around this has changed somewhat in the last few years, because when I was implementing the PROS program, I seemed to have very little patience for people who weren't willing to move forward with this concept of rehabilitation and recovery. But then I started to think to myself that, if I worked 30 years in an agency and all of a sudden this came in, what am I going to do? How would I adapt to this? And so I think there's a couple of strategies that people can use. I've done this with agencies that we work with on a regular basis, because this is one of the biggest hurdles to really being successful implementing an electronic health record. One thing is I let people feel like they're a part of the implementation process. We just don't, okay, we're implementing this tomorrow. We go through a whole process of talking about, what does this have to do for you? How does it have to work in your workflow? Yes, it's going to change workflow. And yes, there's going to be some hard decisions that you're going to have to say to people, this is the way it's got to be done. But there is opportunity for you to make some adaptations to that. Secondly, I believe you need to do this, build this slowly in through your supervisory meetings, through your management meetings, when the executive director has full staff meetings. And the way you do that is to just start to show, this is the data that we need. This is the information that I used to present this to you. And I got this because we had access to this kind of information. Or I used this data to make this decision. Start to incorporate this concept of information being valuable in the decision-making process, and then people are going to want to use it more. And lastly, I think it becomes down to individual supervision pieces, where if you really have someone who's struggling, it's one thing if somebody is fighting against it. If they're fighting against it, you're just going to have to make a supervisory or management decision. Either they fit with who you are and where your organization's going, or they don't. I think that you need to look at the opportunity of partnering people with someone and saying, I know you're struggling with using the software or using how you use this information. Johnny over here is really good at it. Work with Johnny. Let him help you through this, or let her help you through this. So I think if you use those strategies, I think you'll start to see a really good buy-in.
Well, thank you, Dave. I have another question here, and that is, agencies come in all sizes. You've got the smaller organizations who might be able to be a little bit more nimble in decision making, and then you have larger organizations that actually have a back room to support some of these changes, but aren't as nimble and can't be as quickly to turn around and make these significant changes. Can you give some advice to both size organizations?
Yep. Let's go with the larger agencies first. The larger agencies that don't have an inclusive process and they let these decisions be made at the backroom level or the executive only level are going to be those ones that are not going to survive. We've seen this in organizations over the past number of years that have gone out of business, in which they weren't listening to the people who were delivering the service, or they weren't looking at the information they had at their fingertips about trends in what was happening in their organization. And those organizations, it may be nice to have that back room who can gather this information and provide it, but if you don't let the whole organization use that data or be part of that decision making, then you're really going to struggle with being successful and being able to adapt quickly. Now, even big organizations can adapt quickly because they have staff that they can kind of move from one place to another that a smaller organization may not have. Now, if you're a smaller organization, you have a couple of benefits and you have a couple of complexities that you have to overcome. If you're a smaller organization, then you have a much more direct contact with the people providing service and the individuals who are receiving service. So your feedback loop, your ability to be inclusive is a little bit easier. You have flexibility in that you have a finite number of staff, you have a finite number of programs. If you're going to make a shift, you will just shift people over into that area. Now, where you struggle is if that person doesn't have the skill level you need, or you need to expand and you don't have the resources to really add people on, even though you know in the long run that's going to be the right thing to do. So there are, there's benefits both ways. I would say that the one common denominator that both kinds of organizations need to use, in fact there's sort of the three, is one, this idea of being accountable. Build that accountability whether you're big or small. The second one is to use the informed decision-making process throughout their organization. And the last one is be inclusive in your decision-making process, or you're not going to be able to be adaptable to new change, because you're going to always have people fighting it. If they don't feel a part of it, they're going to question it, and even though they may not outwardly fight something, they're going to be slow to adapt to it.
Thank you so much, Dave. I don't see any questions here, so I think we'll wrap it up. And again, I'd like to thank you, David, for a fantastic presentation. And I want to also express my apologies to everyone regarding the technical difficulties that we experienced early on. Everyone will get a copy of the PowerPoint, and additionally, this has been recorded. And so give us a few days at NIAPRS and we will have it up on our website if you want to listen to the audio again. On behalf of NIAPRS, New York Association of Psychiatric Rehabilitation Services, we thank you, and be looking for the next email or e-news that talks about the upcoming MRLCs. Thanks so much. Bye-bye.
Thank you, everyone, for participating.
you.